So now let's go on to looking at some of the systemic changes that we see with age, changes to whole body systems. And they're pretty substantial, but again, recognize that many of the changes that we see physiologically don't necessarily exert a strong functional effect. First one that we're going to start with are changes to the cardiovascular system. And we'll specifically talk about the cardiovascular structure. The first organ that we'll talk about is the heart, certainly the most important organ within the cardiovascular system because it acts as the pump. So it's interesting to recognize that actually the heart doesn't change a whole heck of a lot. The mass of the heart might actually increase slightly with age, primarily due to a slight thickening of the left ventricle in order for it to pump against some of the increased pressures that we see in the arterial system, which we'll get to, we'll talk about in just a little bit. The more interesting change to the myocardial mass isn't necessarily in mass, but it has to do with the tissue composition. And we actually see with age that the connective tissues that run through muscular tissue, and the heart certainly is a muscle, primarily this connective tissue called collagen, which is a very stiff connective tissue, begins to increase in volume as we age. So the heart itself starts to build more of this fibrous connective tissue. And what it then causes is that the heart isn't able to expand as much or fill with blood to as great of a degree because of the stiffness that we get during the aging process. Additionally, there are some electrical changes within the heart as well. There are specific nodal fibers that are able to generate and then propagate an electrical current through the heart, which allows us to have our heartbeat. And these nodal fibers also see kind of an increase in these connective tissue proteins that end up sort of slightly messing up the conduction capability, and it slows down the nerve transmission through the heart muscle and also can make it more likely for the heart to throw what we call an arrhythmia or an irregular heartbeat. And older adults are particularly at risk for a certain arrhythmia called atrial fibrillation, where the top part of the heart starts to function not optimally and starts to speed up, and it causes some issues there. And some older adults need to be on medication for that, and others might even need something like a pacemaker to be implanted to deal with that issue. Then as we move on to the blood vessels, we've got actually we have three distinct parts of the blood vessels. We've got the arterial system, we've got the capillaries, and then we have the venous system. So we'll start with the arterial system. And the arteries are very thick vessels that have a reasonably thick amount of smooth muscle running through the walls of the vessels, and that allows us to expand or dilate or contract or constrict those vessels and help us to redistribute blood flow to parts of the body. For example, when we exercise, we get very good at dilating the parts of the arterial tree that go to skeletal muscle so that we can enhance blood flow to skeletal muscle. Well, with age, again, we see these connective tissues begin to kind of work through that smooth muscle, and then along with the calcification that we see within some of the other tissues of the arterial vessel, we see that the artery itself becomes much less able to dilate or expand. And this is the primary reason that leads to the increase in blood pressure that we see very often in older adults, and also can lead to issues with redistributing blood effectively. Most older folks aren't able to get as much blood to skeletal muscle because we can't change the diameter of vessels as well as we used to when we were younger. Now moving on to the venous system, the other side with blood coming back to our heart, we notice that the veins go through a lot of changes as well. The veins usually are very thin-walled vessels that can accommodate a lot of blood, and we actually get blood back to the heart through muscle contraction that squeezes those veins, and they have one-way valves, so the blood is always going back toward the heart. Now what happens with aging is that the thickness of these veins, the walls of the veins, actually again becomes thicker, less compliant. They're not as able to kind of expand as they were before. The one-way valves that exist within the veins start to malfunction to a degree. So very often we see blood that sort of backs up or hangs out in the veins, and it causes veins to take on this very distended look, or what we call a ropey look to the veins. Additionally, when blood pools in the veins, we actually see, usually in the lower extremity, that some blood actually kind of leaches out to the surrounding tissue and shows that spidery look that we would associate with varicose veins. So those things both happen to the venous system. Then we move on to the blood. And the blood itself actually undergoes some changes. We see a reduction in blood volume with age. We usually will lose up to about half a liter of blood by the time someone reaches the age of 70, primarily due to this loss of body water, because most of the blood is water. And we also see reductions in red blood cell content. We actually see a smaller number of those cells, erythrocytes, that carry oxygen on them through the blood. So not only do we have less blood itself, but we also have less oxygen carrying capability per unit blood. And that can certainly lead to issues with the ability for an older adult to tolerate exercise in an easy fashion.
Go ahead.
And these structural changes also lead to some functional changes with age. Specifically, we'll take a look at heart rate. Now, because we slow down the conduction time of the electrical signal through the heart isn't able to generate as fast as a rate as we age. So we actually see reductions in maximal heart rate during times of exercise or other physical stress. So we actually usually attribute max heart rate to be a function of age, being 220 minus age. Now that doesn't necessarily really fit very well with older adults. It tends to get much more variable as a person ages. So although that equation isn't a very accurate equation, it does demonstrate that maximal heart rate is a function of aging. We don't notice that there are big changes in resting heart rate for older adults. That tends to stay pretty normal throughout life. Then we move on to stroke volume. So stroke volume is the amount of blood that can be pumped per beat, per ventricular contraction of the heart. And stroke volume, due to the fact that the myocardium stiffens and it's not able to accommodate as much blood, and we also have reductions in blood volume, we see pretty significant decreases in stroke volume with age. And that, combined with the lesser maximal heart rate that's able to be attained, is the primary reason that we see these big reductions in maximal cardiac output, or the amount of blood that can be pumped out of the heart per minute. And these things relate strongly to the reason why we see big losses in maximal oxygen consumption, or VO2 max, the amount of oxygen that tissue can use to produce energy during our life and during exercise, because these cardiovascular factors start to reduce the ability to actually get the blood and the oxygen to tissue at the same rate per unit time. And finally, we've already talked a bit about the fact that this thickening of the arterial vessels and the lack of ability for them to expand, a process called arteriosclerosis, leads to an increase in blood pressure, or ultimately pathologically hypertension. We also see older adults have a greater likelihood of having transient periods or short periods of very low blood pressure, something that we call hypotension. The reason why this happens is we do have some sensory fibers at different places in our arterial tree, specifically in the arch of the aorta and also the carotid arteries. And their job is to monitor pressure of blood against the walls of the artery. That's basically what blood pressure is. And they begin to not be as sensitive with age, and they begin not to inform the central nervous system of changes quite as quickly. So very often we have older people who go from a laying position or a seated position quickly to a standing position, and they're not able to accommodate that change in body position, and therefore they're not able to get enough blood up to the brain. Well, you know, what does that do? That makes a person a little bit dizzy, a little bit woozy, and certainly in certain circumstances it can lead to a dangerous and injurious fall. Now we're going to move on to another system, kind of related to the heart and the vessels, the pulmonary system. Now the pulmonary system is a system that actually has a great reserve capacity in most people. In other words, the lungs actually tend to work a lot better than they have to. They're one of the best functioning organs in the body in a healthy person. So a lot of the changes that we see with the lung won't necessarily affect function to a great degree, but we still do see some changes. First of all, we see the loss of elasticity of lung tissue. You can imagine, because lungs fill with air, that lung tissue is very compliant, it's very elastic. But similar to what happens with the myocardium and other tissues of the body, we begin to see a greater infiltration of those stiffer connective tissues to work their way through lung tissue, and it causes us not to be able to expand lung tissue to the same extent as we could when we were younger. Additionally, we see big changes to the compliance or ability to expand the chest cavity. The chest cavity itself, the thoracic cavity, is comprised of the chest wall, which has in it muscles, the intercostal muscles, which are between the ribs. Ribs are bones. And then we have the sternum, which is another bone. And then we have a bunch of cartilage that helps to connect the ribs to the sternum. Well, all of those tissues also go through some age-related changes that cause them to be less compliant and less easily expanded. So therefore, we tend to see the inability for people, older people, to really bring in as much air into the lungs. We also see that air distributes itself much less evenly with age. Many older people have trouble recruiting the muscle called the diaphragm. It's a dome-shaped muscle that exists and separates the thoracic cavity from the abdominal cavity. And when it's contracted, it actually domes down into the abdominal cavity, thereby expanding the thoracic cavity even more, which then draws air into the lungs. So what happens with age is many older people lose their neural connection. Their brain doesn't connect with their diaphragm nearly as well as it used to, and therefore they can't depress the diaphragm as well, and therefore mostly the lower portion of the lungs have a tough time being filled with air. And what we tend to see in older people is that they become chest breathers. So one thing that I do in almost every exercise class I do with older adults is we do some deep breathing exercises where I have them place a hand on their chest and a hand on their stomach, and I ask them to really feel as though when they take a deep breath in that the hand on the stomach is the one that comes out and the hand on the chest doesn't. And that would indicate that we're able to depress our diaphragm. But most older people, even when they think about it, most of the movement comes from the chest. They are chest breathers. Now, all these changes ultimately result in the loss of the ability to fill the lungs with air effectively. We call the maximum amount of air we can bring into the lungs vital capacity. And people by the age of 75 or 80 typically show about 50% losses in vital capacity as compared to when they were younger. Additionally, we have trouble getting as much air out of the lungs. We can't vacate air from the lungs as well. And we see a 50% increase or so in having air left over after breathing out, which is called residual volume. Now we're going to move on to the neuromuscular system. And the neuromuscular system is very different than the pulmonary system. The neuromuscular system does not have a big reserve capacity during the aging process. And some of the changes that we see, just specifically due to physiological aging with the neuromuscular system, can have real profound effects on function. So it's important to recognize that this is a biggie when it comes to its effect on a person's life and their ability to do different things. The first thing that we notice is changes within the nervous system. We'll start with the brain. So the brain is one of those organs that we're constantly learning new things about. We haven't even really scratched the tip of the iceberg, and we don't always know that if there are observable changes in the structure of the brain, if that actually results in real functional changes. One thing is for sure, we know that by the age of 70 years old, most people have lost about 10% of their brain volume, their brain mass. And that's typically due to the loss of both neurons, you see a neuron there on your slide, and also their support cells that help keep neurons kind of functional and alive. Additionally, neurons need to communicate with one another in the brain. The way they do that is by producing and releasing what are called neurotransmitters. And neurotransmitters are chemicals that allow one neuron to pass on a message to an adjacent neuron. And what happens with neurotransmitters in the brain with age is they become produced at slower rates and therefore released in lower quantities. The combination of the loss of neuronal structures and their support structures and also the reduction in neurotransmitters results in a much slower nerve transmission time as we go through the aging process. And it really slows things down and affects reaction time. So what I like to always ask any student of mine that wants to get involved with my research, I ask them first what kind of some of their thoughts are about older adults, because many of them have never worked with an older adult before. And almost to a number, each of them at some point within the first 5 minutes will tell me, man, they are the slowest drivers. They drive so slow. And, I agree with that. They are pretty slow drivers, but start thinking about this. If they actually drove like maniacs, like we all tend to do, we'd probably see a lot of bad things happen. We'd see accidents, we'd see all sorts of terrible stuff going on. And actually what's interesting, I'm in my late 30s, and I've noticed just over the last couple of years that I've just started driving slower. I don't know why. I've put my other hand on the wheel. It's kind of odd. I look at it, I'm like, man, I never used to do that. And I'm driving slower. I just don't feel like I'm in that much of a rush. So I don't know if that's just me, if that has something to do with my brain or what, but I think that's kind of interesting. Then as we move on, there are some other changes that take place within the neurons in the brain as well, specifically here within the motor cortex, the part of the brain that has neurons that control skeletal muscles within the body. And the last change that occurs within the brain is probably the most important functional change. That actually affects the motor unit, so the motor cortex is part of the brain near the front, that has neurons that connect to and control skeletal muscle contraction. And what we notice with age is that we have two types of motor units. A motor unit is a neuron and all of the skeletal muscle fibers that it innervates. And usually it innervates many muscle fibers. And we have two types of motor units. One called type 1 motor units, which control endurance-like muscle fibers, smaller muscle fibers that contribute to long duration activities. And then we have type 2 motor units, which are motor units that control muscle fibers that result in strength and power and being able to express strength and power. And we find that as one ages, for some mechanism that we're not still too quite sure of, that the motor cortex begins to lose the capability of recruiting type 2 motor units. We call this motor unit denervation. And this denervation affects these strength and power motor units to a greater degree than our endurance motor units. And you might think that's not much of an issue with older adults, but as we'll see in just a moment, it is very significant. So as we continue on talking about structural changes to the neuromuscular system, we'll transition to the muscle and connective tissues. As we already said, muscle mass, particularly those larger, bulkier, more protein-filled type 2 muscle fibers, reduce greatly in size because they're no longer being activated by the brain. And at some point, those muscle fibers might actually totally deteriorate and die. Very often, they are replaced by non-contractile connective tissue, essentially scar tissue, or even fat. And we call that cell death apoptosis. That's programmed cell death. And then also we have several hormones that mediate the health of the muscular system, such as testosterone and growth hormone. And those both tend to decrease to a great degree with as people age, which we'll talk about in a little bit. And the combination of these factors leads to a condition that is known as sarcopenia. And sarcopenia, which literally means vanishing flesh in Greek, is a condition where we have such significant losses in muscle mass and such significant losses in force production capability within muscle that we see a person really being challenged by even the most basic functional tasks that will allow them to keep their independence. So unfortunately, as we get to over the age of 80, most folks have lost 50% or even more of their initial muscle mass when they were younger. Along with those changes to muscle, we see serious changes to connective tissue as well. So connective tissue not only connects a muscle to a bone or a bone to a bone or stabilizes a joint capsule, but connective tissue literally runs through an entire muscle. We see connective tissue running all the way from one end of a muscle to another. And with age, again, we see that these connective tissues get stiffer. We see a greater increase in the amount of the stiff connective tissue known as collagen, which causes these structures to become much less extensible, causes these structures to become much less movable, and ultimately may lead to very visible changes in the structure of a person's body. And again, as we see these body positions get very much out of whack as compared to what would be optimal, it's going to alter the ability for the sensory nerves that we find and sensory receptors that we find throughout muscle and connective tissue and joints that monitor where the body is in space. Well, if the body is significantly distorted out of optimal positioning, then this proprioceptive function isn't as good. We're sending information to the brain about the position the body is in when it's in very poor position, and it doesn't respond as quickly to changes in position, which ultimately can lead to things like serious problems with ambulation. We see gait and shuffling problems while a person walks, and we also see significant losses of skeletal muscle integrity with age. So let's talk about how these structural changes result in changes in function. We typically see actually a slightly greater decrease in muscle power capability, or the ability to produce force quickly, than we do with muscle strength, probably because we see that preferential loss in the type 2 motor units versus the type 1 motor units with age. And as we see those strength deficits and power deficits take place, we also see changes, again, in posture and also gait, or the way a person walks. And all of these things contribute to what I call a loss of recoverability, the ability for a person to be able to recover once they get outside of their own bounds of being able to maintain balance. So if a person perhaps stumbles after tripping over something, if they can't recruit muscle fibers as quickly, if they can't get those strength power muscle fibers to contract, and if they don't necessarily know as well where their body is in space, instead of being able to recover from that stumble, they end up hitting the deck. And that's probably one of the primary reasons why accident-related falls are the 6th the highest cause of death in older adults, and they actually result in more accident-related deaths than even automobile accidents do in older people. So unfortunately, the tissue that tends to take the most damage from these falls isn't the muscular system, it's actually the skeletal system. The skeletal system, which we see undergoes some significant changes with age as well. In fact, the Centers for Disease Control state that over 400,000 fractures are sustained every year by older adults in the United States. And, you know, the structure of bone as a living tissue is kind of interesting. We're constantly laying down calcium on a protein matrix and then taking calcium off of that protein matrix. So bone is constantly turning over. It's an alive tissue. And what we see with older adults is that those cells that mediate the deposition of calcium, known as osteoblasts, those cells actually decrease in number and decrease in activity with age, whereas the cells that are responsible for bone destruction or removal of calcium from bone, called osteoclasts, pretty much stay the same in terms of their activity with age. So ultimately, kind of the end result is that we reduce bone mineral density, or the amount of mineral that we find per unit bone structure. Now on the top here on this slide, we see very healthy trabecular bone. Trabecular bone is this lattice-like network of bone that we see usually at the end of long bones and some other places in the body. And trabecular bone is able to, I mean, a bone like that, you can tell, can withstand forces from a lot of different angles. It has really good integrity to it. Well, as time goes on and we start to see decreases in bone mineral density with age, which is actually even more in females than males, females after the age of 30 will lose about 8% of bone mass per decade. Males, it's somewhere around 3% of bone mass per decade as a result of the biological aging process. And there are some reasons that we won't get into as to why women lose more mass than males. We recognize that once we reach much older age, females will reach a period of time called menopause, where estrogen, which is their primary sex hormone, begins to be decreased, and ultimately the production within the body of estrogen totally gets shut off. And that causes them to have a massive decrease. In the 5 to 10 years following menopause, females might lose up to 25% more of their bone mass. So we see very, very large decreases in bone mineral density in that period of time. Afterwards, they slow to a reduction of about 1% per year, which tends to be about the same speed as males as they reach older age. So ultimately, we end up seeing the situation at the bottom of the slide here, which would be that same trabecular bone, however, once it has significantly lost bone mineral density. And it's really not difficult to tell now that a simple fall or even some impact against that bone can cause a fracture.